Hospital of Strasbourg here, a member of ERCAD, and this afternoon I will try to explain you how to do a laparoscopic adrenalectomi. Who has some experience in that kind of surgery? Okay. So, the best indication for beginning laparoscopic adrenalectomi is small secreting tumors, Kurkos tumors. Caching is a little bit more difficult because you have more fat around, but small tumors, of course, are the best that you can remove. Are there some contraindication for laparoscopic approach? Age today is not a contraindication, it's a good indication because we have less postoperative problems. Cardiac and respiratory failure, the anesthesiologist will ask you to do it by laparoscopy because the outcome after surgery is better. Obesity is also a good indication because you have not so large scars to perform, and just with 3 or 4 trocars you are able to remove the glands. Cranial hypertension is no more a contraindication. Coagulation disorders, when they are controlled, is not a problem. Today we are operating with aspirin. For the other one, you have, of course, to stop them and to do low weight heparins for doing that. Is a problem of size a contraindication, and what's about malignancy? First, the size of the tumor. In 1996, at the beginning of this kind of surgery, it was said that 8 centimeters is the largest tumor that you can remove by laparoscopy. It was said by Jean-François Henry, that was one of the pioneers of that kind of surgery. And the same, 3 years later, say, okay, you can go up to 12 centimeters, and you can also remove some potentially malignant tumors by this way. The pheochromocytoma is no more a contraindication to laparoscopy because you have to prepare your patient, and there are no specific complications with pheochromocytoma. Of course, when you have a malignant pheo, you have to follow the same rules as for the other cancers. The problem specific to incidentoma, you know that when ultrasound appears, we found a lot of nodes or tumors on the adrenal, and the question is, when have we to operate that small tumors? Today, there is a consensus for no indication for small tumor resection less than 3 centimeters. That means that they are not secreting. It's an incidentoma. It's just because you did a CT scan or ultrasound and you found something on one of the glands. Even if surgery is minimally invasive, you can have some problem for that, and less than 3 centimeters with no other things, there is no indication. For the tumors that are more than 3 centimeters, of course, there is an indication because you can have some adenomas or some potential malignancy. The indication is removal of potentially malignant glands also, and that gives us the next topic is laparoscopic and cancer. I'm following the rules that were announced by Quan Wan-Diu from San Francisco. You can operate an adrenal cancer if you don't make any rupture of the capsule. If you make any rupture of the capsule, you will have a big risk of carcinosis, and you know there is no chemotherapy, there is no radiotherapy at all for curing that. So it's totally catastrophic when you are disrupting the capsula in cancer of the adrenal. For metastasis, the rules are the same. You can remove the metastasis if you have no local invasion. And for the cortical cancers, you have to be sure that you keep far away from the tumor. In this case, you can do it. Remember also that you can have some invasion of the veins. And when you have carcinotic invasion of the vein, there is a contraindication for laparoscopy. It's like a rupture of the capsule. Laparoscopy is okay for small tumors, that means 6 to 7 centimeters. And if you see any problems of invasion, any problems of inflammation that makes the dissection very difficult, please convert first, because you never know exactly where you are and what happens there. That's in case of malignancy. Going to the operating room on the left side, you see we are placing the patient totally on the side, and we are putting 4 trocars. Here is the view that you can have on the left side. Remember, the patient is on the side, and the first moment is to remove the peritoneal sheet between the spleen and the wall. That helps for falling down the pancreas, the tail of the pancreas, and the spleen in front of the patient. So you will have to make a very large dissection of the peritoneal sheet just to allow that book to open. You have the spleen that is falling down, taking with her the pancreas, and you will see here appearing the splenic vein and the splenic artery. That is one of the landmarks that you have to see when you are doing a laparoscopic approach transabdominally on the left side. You see very gently we're opening the tissue that are behind the pancreas. We don't want to see the adrenal gland. We have just to look at the vascular landmarks, the vein and the artery of the spleen. After that, we're dissecting quite deep, so we open largely that space. And when this is done, after that, we can have a look to the lower, the main adrenal vein. Sometimes you see the adrenal, sometimes you don't see it. Here you see the tail of the pancreas is quite far away from the region of the adrenal. We never take the tissue with the graspers. Here you see the peanut that is just retracting very slowly the tissue in order to have a good dissection. The next landmark that you will have to see is the renal vein. I hope you are able to find it easily. That's not the case for the digestive surgeon at the beginning. And after that, at the upper edge of that vein, you will find the main adrenal, and you are dissecting behind. Be sure that you make all the way for putting some clips. You cannot use ligature or a harmonic scalpel for removing that vein. You have to use clips. If you cut that vein close to the renal vein, you know that's a hole in the renal vein, and it's very difficult to cure afterwards. The dissection follows until the diaphragm, and you will find some other veins and arteries on the inner side. There's a medial artery. There's also an accessory vein that is going to the diaphragm. And so very slowly we dissect the inner side of the gland. Until here, we never saw the adrenal gland. That's not the purpose. We have to remove all the fat around the gland to be sure that we are removing all the gland out of the patient. Here you see some colors that indicate that the adrenal gland is in that fat. Here you have that accessory vein going to the diaphragm. Sometimes you can find this vein very close to the main adrenal vein, and that basically that accessory vein is going inside the proximal part of the adrenal vein. When this is done, you have some small vessels at the lower part. You have an inferior vein and artery, but here the major work is done. Superior artery sometimes, not every time. At the upper part, you can clip it, you can burn it, you can use the ligature for the arteries. It's not a problem. Here we choose to put some clips, and when this is clipped, we will see behind the muscular wall of the abdomen. The inferior dissection is close to the upper part of the kidney. There is a mistake that you can perform with the upper branch of the renal artery, and so you have to take care when you see artery to be sure that the artery is going inside the adrenal gland and that's not a separately branch. We are opening all the fat above the kidney, and here very slowly we're dissecting the lower part of the adrenal gland. You see some beating behind, that's the renal artery or a part of that, and here some small inferior artery, and we have to be sure that that artery is going inside the adrenal gland before removing. After that, the work is quite done. You have some small vein that remains, so you can cut it or burn it without any problem. And at least you are freeing totally that corner from the gland and the surrounding fat. We put it in a bag and we take it out. Sometimes we have to enlarge a little bit one of the openings, or making the opening between two trochers, and you see that's a gland of quite 7 centimeters that was taken out with the fat around. Here on the left side there is a little duplicated vein. This is the main vein, and you see 1 centimeter closer to the kidney you have a second vein, and of course you have to take care to that abnormalities to be sure that you have no bleeding during the surgery. On the right side it's exactly the same. We're putting the patient on the left side, so the right side is at the upper part, and the first task is to remove the attachment of the liver to the vena cava and to the peritoneal sheath covering the adrenal gland. That task is done very slowly. We have to push in front the liver. Remember also we are on the lateral side, that means that the gallbladder is very far away, and you are just in front of the vena cava. So very gently we are removing that ligament of the liver. In order to have enough space, the liver will fall down in front of the field. You see the vena cava here very easily, and after that we will have to remove all that attachment, just to have a good opening of the peritoneum and of the place between the adrenal gland and the vena cava. The dissection is performed very high. This attachment will be they will come back a few days after the surgery, so there is no danger for the liver. And you see very gently we're opening the peritoneal sheath before we are going in the deepness and looking for the main adrenal vein. Here you see also the peanut that is used to avoid to take with the grasper any parts of the gland or of the peritoneal sheath. Usually we're keeping on the right side to the liver, on the left side to the spleen, 1 centimeter of peritoneum if you need to have a special traction in the case of bleeding. Keep 1 centimeter here so you can take it and make some retraction, additional retraction if you need. And thanks to that dissection, very extensive to the diaphragm, you have the liver that is falling slowly down. Of course, you have to take care of the veins going from the liver inside the vena cava, and sometimes you have some abnormalities with lower veins or upper veins, and not just the 3 main veins that you expect. Here the way is open between the adrenal gland and the vena cava. All that adhesions are removed. When you're operating very slowly, you see very well that anatomical landmarks. And of course, here the purpose is to have a look to the main adrenal vein. That is quite short on the right side, it's longer on the left side, going inside the vena cava, and that makes the difficulty of the dissection. If you disrupt the vein, you have a hole in the wall of the vena cava, and it is very difficult to fix because you cannot clip it. Putting a clip on a hole doesn't work, and so you have to put some stitches. Here the main vein is appearing. The dissection is performed at the lower part, behind, at the upper side. Before applying clips, you need to be sure that all the sides of the vein are totally thread, and after that you can put some clips on it. You see you have less than 1 centimeter between the vena cava and the adrenal gland. The peanut is coming also for helping for retraction. Sometimes you have some oozing of blood because there are some small vessels on the posterior aspect of the vein that are bleeding when you make the dissection, even if you are doing that with the cautery. That dissection can be performed here with the scissors or with the hook, that are the best instruments to do that, and after that, cutting between the clips, the veins. It seems to go very slowly, but you have a large part of the operation here that you can follow. And you see we're looking all the time for free tissue close to the vena cava, and we never go in the fat surrounding the adrenal gland. At the upper part you will find again the wall, and that gives you the end of the dissection. We have usually one accessory vein that is going directly also in the vena cava. I think that's the dissection of that vein here. It's exactly the same problem that with the main vein. It's a little bit smaller, but you have exactly the same problems of risk when you're making an injury of that vein. Here the dissection comes to the posterior aspect of the vena cava. You see here, because there's not a lot of fat surrounding, you see very nicely the adrenal gland, but we try to keep as far away as possible to avoid any spillage of cells in case of malignancy. That's a posterior artery that will be cut. So we go a little bit quicker. Here you see this is a dissection of the upper adrenal accessory vein, and the dissection between the liver and the wall are performed there. Thanks to the retraction, you have a very nice tissue that can be opened very easily with the hook. Here you see the muscle behind, and that is the landmark you need to find before you are going on another location around the gland. When the inner part is done, we're going at the upper part, and very close to the muscle, really, we try to remove all the fat of that region. Here you see it's a little bit more tricky for the upper part with small ligaments here, but at least you can free totally that region and discover a posterior plan that is very easy to dissect. After that, you have to come down and going close to the renal vein again. The situation is quite the same that on the left side. The vessels are quite a little bit longer on the right side, and so it's easier to make the lower dissection of the gland. During the dissection, you need absolutely to avoid any bleeding, because when you have some bleeding, you cannot find the anatomical landmarks. Here you see some bleeding coming from the lower vein, close to the renal vein. Bipolar cautery helps to solve the situation. Here you saw in the two cases that the dissection is performed with the hook and with the scissors. The hook and the scissors are nice instruments at the beginning because they are not destroying the anatomical plane that you need to find for making a proper resection of the adrenal gland. Of course, you will see we can use also the modern energy devices, harmonic scalpel or ligature, but with that devices, when you are at the beginning of experience, it's more difficult to understand the landmarks, and you are destroying it because you are sealing it together, and it's better to open the spaces. Here the last fatty tissue, and of course here also the gland is removed inside the bag. Some difficult steps on the right side. Here you see an inferior adrenal accessory vein that we have to handle with. It's like a main one you can use here. You see the angled dissector for going behind. In some cases you have a real superior arterial accessory vein. You think that there is nothing more at the upper corner of the adrenal vein, and sometimes you find some small vessel here. So, complications. The specific complications on the left side are the complications related with the mobilization of the spleen and with the mobilization of the pancreas. Sometimes it's not so easy to understand where the pancreas is, and in some cases you can go between the spleen and the pancreas and you find some bad tissue, fatty tissue behind your spleen. It's the pancreas, and so you have to go down to the kidney for going behind the pancreas. The pancreas tail can be normal, sometimes it can be also enlarged, and here you see a very large tail, and it's quite difficult to make the retraction here. You have to be sure that you are going behind the pancreas and not making any injury for the pancreas. The diagnosis of cancer, you know, it's rare. It's 0.02% of all the cancers, and we have very small cases in the year in France, but when you're looking at this, you have to avoid to use the staplers, the graspers. You have not to destroy the gland, you have to keep outside. When you are doing that, it's a really bad result that you will have, and you can have some spillage of vessels. The invasion of the vein is another concern. Here you see the vein remains a little bit bulgy, and the operator see that something is not totally normal. And when you are beginning the opening of the vein, you see what happens inside. That is a really bad situation, and so you can avoid that with a very good analysis of the CT for looking if you have something inside the vein, or with some Doppler ultrasound to be sure that your vein is free. And if your vein is not free, this is a case for conversion. It's a little bit late to convert, of course, but usually do it by open way, it's more secure. Vascular injuries, here it's on the right side, so you see very small bleeding coming from an artery that was opened during the dissection of the main adrenal vein. With the clip device, the surgeons think that he is able to find some suction, lavage, and after that, when you see really what you have to clip, you can clip it. Don't put any clip blindly inside, because when the clip is applied, you cannot make any coagulation on it, and you cannot use ligature, so such things, and sometimes you make a situation that is more difficult. Here's a retroperitoneal approach. It's the Anatoly from Roma that is making that operation, and you see the vena cava in the deepness here, so he's wishing out the glands, and when he's doing that, look what happens. A small opening of the vein. You think we have to convert the patient? Suturing, old-fashioned. You will see the solution. Remember that you are in a retroperitoneal approach, and usually the retroperitoneal approach, they have a very big pressure, up to 30 millimeters of mercury. Here is applying Flucil, is putting some sponge on it just above the hole, waiting 3, 4, 5 minutes, and you ask the nurse to prepare the stitch. But there is no longer need for a stitch. Intraperitoneally, it's not exactly the same case. but retroperitoneally you can try to do that. Here is Dr. Inadmet from New York that operated one patient. He likes clips. He has a clip addict. And so you see a lot of clips here in that region, and he have a little bleeding. So he takes again clips. He tried to make some coagulation, but it doesn't work because you have the clips. When you are coagulating on a clip, it doesn't work. Remember that an interesting instrument is a sponge that you are putting inside, because that allows you to wish out the blood, to make some compression. It's a very nice instrument. You can help with the coagulation. And when he see better his field, he can try to put again one other clip. And you see the artery that was cut on the second side. The first side here, you see the small artery. It's an artery, it's not a problem of the vena cava here. But he put it here, a clamp. After that, you can try proceed also. Can work in this case. But you need to see here with the clamp, you need to take enough tissue to be able to put one stitch. And in that situation, it's not so easy to do a stitch for solving that problem. So at least he was able to stop. Do some harmonic scalpel, and there is no more bleeding here. This is an historical case. It was one of the first cases we did outside of our unit, and Professor Maesco and Mutter are going oversee for helping operating, and you see here there was a small injury of an artery. They are putting the clip device, and when they are removing the clip device, they take the clip that was on the main adrenal vein and remove it with the clip device. That means that you have a hole in the vena cava. It was beginning of our experience in laparoscopy, so making a knot is a really difficult moment here. It took 1 hour for making one stitch and making the knot with the bleeding. The patient was not convert, and it was they were able to stop that. So here it's a more recent case. It's a pheochromocytoma, and you see it's a very inflammatory tissue around the gland, and here the operator was not able to identify the oozing of blood coming. He has some clips, he has also the bipolar cautery. He could identify the main adrenal vein, but just going behind gives a new bleeding, and in that case it's very difficult to continue the operation, you see, by laparoscopic way. Just putting a sponge and making some compression. Sometimes remember that it's time to convert, and do that by open way. And the surgeon that did that had a very huge experience in adrenal surgery, but in that case, when you have the bleeding, it's really too difficult to perform. You need your fingers inside. So in 20 years, perhaps we will change that kind of situations. The complications, uncommon complications, portal vein transection when you are on the right side, hepatic artery ligation, and so after that you are happy because you can go to the hepatic transplantation. The left ureter ligation, so you know what to do when you ligate an ureter. We call the urologist. And renal artery ligation, it's a nephrectomy. So remember that removing the adrenal glands is sometimes quite easy, sometimes it's not so easy, and you can have some nice complications. To avoid that, you need to have a very good light source and an HD camera in order to see really all the details and landmarks. here the use of ligature and harmonic scalpel. For the main adrenal vein, you can put some clips because the ligature is not enough. This is a retroperitoneal approach. It's Professor Valls that is just using ligature for all the things that you will see, for all the veins and arteries and so on. But again, it's a retroperitoneal approach. It's not a transabdominal approach. Transabdominal, I prefer to put some clips on the main vessels. If you want to go to understand a little bit better, to prepare your operation, you have the preoperative simulation. In our institute, we developed 3D reconstruction of the patient thanks to a CT scan, an injected CT scan, and you see here we have a 3D shaped CT scan able to reconstruct all the structures that are around. And so before the operation, you can mimic the position of the trocars, you can mimic the view that you will have on with the scope regarding the position you have on your patient, and that can be helpful for the surgery. You can also superimpose that images inside your view, laparoscopic view, and so you can have a view below the fat, behind the fat, and you can understand where the major vessels are. That's one of the cases. It's on the right side. It's an adenoma. Here you see the main vein. You see the arteries that you will find during the dissection, reconstruction of all the things. Thanks to that 3D reconstruction, you can remove the bones and you can have a posterior view of the adrenal. That is not really the case in real life. Here, opening of the peritoneal sheath with the harmonic scalpel, and thanks to the 3D reconstruction with the superimposition, you see behind the tissue you have under your view during the laparoscopy, you see where the vessels must be, and so you can prepare better and you can find easier the major veins. Here you see it's totally accurate. You have the lower vein exactly in the good place. We have the upper vein. In one case we did, the computer cytologist showed one location of the main vein, and the surgeon said, no, it's not the position, it must be 1 centimeter below. Where's one? The computer scientist. So, and thanks to the dissection very slowly, we found that the vein was not at the normal location, but a little bit higher. So that can be very helpful to have this kind of GPS during the surgery. Thank you for your attention.